This presentation is going to cover pediatric medication dosing. So we'll go through some phases of talking of the dosing of different medications and how to calculate the math for those patients, since pretty much all pediatric meds are weight-based. And we'll also go over some shortcuts of how to do some quick math in the field. As an overview and review, those kids are extremely susceptible to hypothermia, so I cannot iterate enough how important it is to keep them warm. Cover them up in multiple blankets, turn the heat on in the back of the ambulance, prevent that heat loss. That's pertinent to all shock patients, but most especially the pediatric populations. They're going to be susceptible to hypovolemic shock. They don't have a lot of systemic volume, so they can easily go into shock. So we need to prevent further fluid loss by an instance of, say, hemorrhagic shock, doing direct pressure wraps, using hemostatic agents, and as the last resort, tourniquets on these little kids. Most of the time, these little kids, their muscles or tissues are soft, so pressure will work on them. They don't have really big limbs, so direct pressure and pressure wraps with those hemostatic agents will work. And then ultimately replace fluids with that ALS treatment. So they're going to do 20 milliliters per kilo, and you can repeat that 3 times for a total of 60 milliliters per kilo for these kids. But be sure while you're doing that you're seeing some marked progression with that you're not just giving fluid, and you're not seeing any kind of change. And then with the cardiogenic shock patients, 10 milliliters per kilo, a single dose. Okay, so just be sure you're not diluting the Kool-Aid in these kids too much. We're worried about perfusing and nutrients and ensuring appropriate metabolism. Well, all that with sodium chloride, there's nothing being transported in there. You're only filling the container back up. So as in the picture, we all like that good, flavorful Kool-Aid. We don't like just the water with a tint of flavoring. And that little kid's body isn't going to like that sense either. Dopamine is going to be the first-line vasopressor, which is going to be secondary to fluid challenges. So if those fluid challenges aren't increasing that cardiac output, they need to go to a pressor, and dopamine is going to be the choice. So the dose for that, it depends. It's my physician order of 5 to 20 micrograms per kilogram per minute. So the way that kind of works is it has its beta 1 effects in the 2 to 10 microgram per kilo range. Basically, that's increasing your cardiac output by increasing the squeeze, that contractility, and increasing that heart rate and the automaticity. So it's increasing electrical current, increasing the squeeze, and increasing that heart rate to reperfuse everything. And then it gets its alpha effects over 10 micrograms. So that's what's going to cause that vasoconstriction. So you're going to still have an increased cardiac output by the squeeze, the rate, and the inotropic effects. But then those higher doses is going to start to cause vasoconstriction. So let's do some practice on calculating that dopamine drip for this ped. So let's say you've contacted the physician, you've tried fluid boluses, that's not working, and you've been ordered to give a dose of 5 micrograms per kilo per minute to a patient that weighs 30 kilos. So go ahead, pause video, take a minute, do your calculations. Dopamine, whether it's packaged in a 400 milligrams in a 250 ml bag or 800 milligrams in a 500 ml bag, the concentration on the dopamine that's carried by EMS is 1600 mics per ml. Okay, so when you do the math, go ahead and figure up how many micrograms you're going to need per minute. So just take your weight, multiply that by the dose. So that's going to give you, that's easy math, 150 micrograms, what you need per minute. So start solving that out. You got your 150 micrograms in a single minute, and then you're going to multiply that by the concentration. 1 milliliter is 1600 micrograms. And we write this concentration like this so we can cancel out those units. Then we're going to multiply that by our drip factor. So that's 60 drops, 1 ml. And again, crossing out those units. Okay, then we solve. That's going to come out to 9,000 over 1,600. That's your drops per minute. But breaking that down even more, that comes out to 5.6 drops per minute. So let's do a shortcut. Less complex math, just some different numbers you need to remember. Okay, so in this same thing, we need to figure out how many micrograms we need, and we're going to multiply that by 0.04. So again, now we need 150 mics, and that's based off of the 5 times the 30. So 150 times 0.04, that gives us 6 drops per minute. When we did out the previous math, that gave us 5.6 drops per minute. And with this, we're titrating to effect. For the hypoglycemic pediatric patient, they're going to receive D50, and the dose of that D50 depends on the patient's age. So for patients less than 1 month old, they get D10. For patients 1 month to 2 years, they get D25. If they're over 2 years old, they're getting D50. So the way you prepare D10 is you leave in 10, because in that D50 vial is 25 grams and 50 mLs. So just leave in 10 for D10. So you'll squirt out 40, leaving in 10, and then fill 40 back up with just normal saline. So you'll have 10% or 10 mLs of that D50, then put in 40 mLs of normal saline, and that'll get you your D10. And D25 is the same way. Leave in 25 and then fill the rest back up with normal saline. Okay, so let's do a scenario here. So say you've got a kid that is 2 weeks old and weighs 6 kilos. How much D10 is that kid going to get? So basically, you're just going to take your 6 kilos times that 5 mLs. It's going to give you 30 milliliters that you're going to inject in them. So remember, you took your D10, you left in 10 milliliters, and squirted out 40. So now if you got 10 milliliters of D50, you're going to fill that whole syringe back up to get that full 50 mLs to get your D10. So for this kid, you'd give 30 milliliters of that D10. In this scenario, let's say you've got a 16-month-old child whose hypoglycemic blood sugar is 40, they're unresponsive, and now you got to give D25. So you'll begin by preparing that D25, leave in 25 milliliters, squirting out 25 milliliters, refill that 50 milliliter syringe with 25 milliliters of normal saline, and preparing that D25. So for them, you're going to do 2 milliliters times their body weight of 10. So that's going to give 20 milliliters. So of your D25, you'll give 20 milliliters from that 50 milliliter syringe. And in this scenario, you've got a 5-year-old that weighs 25 kilos, pretty hefty 5-year-old. But the kid's unresponsive, blood sugar is 40. So if they're over the age of 2, you don't have to do anything to D50. Over 2, just leave it true. Okay, so this kid is 25 kilos. So you're going to take your 25 kilos times 1. 25 kilos times that 1 ml. Easiest math you've had to do so far. 25 milliliters out of that 50 milliliter syringe. With Tylenol, the dose of that is 15 milligrams per kilogram. That's indicated for kids with a fever over 102 degrees Fahrenheit, and if they have not taken any Tylenol in that past 4 hours. The concentration of the Tylenol that we carry on the ambulances is 160 milligrams per 5 mLs as pictured. When you break it down, that's 32 milligrams per single milliliter. All right, so let's take a scenario here. You got a 10-kilo kid with a fever of 104, and you got to give him some Tylenol because that's over the 102 as the protocol says. So you'll take your 15 milligrams per kilo times that 10 kilos, so they need 150 milligrams. So to calculate how many mLs you're going to need, you take that 150 milligrams times that concentration of 1 ml equals 32 milligrams. So those units cancel out, and that comes out to about 4.7 milliliters. So basically, if you take your dosing of 150, just divide by 32, that's going to get you your 4.7. Versed is indicated for that patient in status epilepticus, meaning that they're having a seizure that lasts 2 minutes or longer, or they're having consecutive seizures without regaining consciousness. So the dose for that is 0.1 milligrams per kilo, and that's if it's IV, IO, or IM, and double the dose 0.2 milligrams per kilogram if that's going atomized intranasally. And with Versed, it comes in a variety of concentrations. Most generally, you're going to find it in a 1 milligram per ml vial or a 5 milligram per ml vial. When it comes to dosing and administration of the Versed, those 1 milligram per ml vials are going to be much easier for kids. Otherwise, you're going to be drawing out, those little kids less than a single ml of Versed to administer. So you get that better concentration, it's easier for dosing. Okay, so also to consider something, if the kid weighs over 20 kilos, they're going to be getting the adult dose, because if the kid weighs 20 kilos, that's a dose of 2 milligrams. That's the same dose that the adults get. So those little kids, if they're 40 kilos or whatever, they're going to still get 2 milligrams, the same dose those adults are. So at 0.1 milligrams per kilo for a 10 kilo kid, that's easy math. That's 1 milligram. So if it's 1 milligram per ml, that's an easy thing. You draw up the same amount of milliliters as you do the milligrams that you need. Simple, simple math. When it comes to pediatric dosing, be sure that you know how to do the fundamental concepts of the math to check yourself. Otherwise, I always recommend use that Broslo tape. It's got all the dosing, everything you need on there. Also recommend, and this is my personal preference, to make cheat sheets so you don't have to do the math. Do the math ahead of time, then you got quick reference charts. I like a cross-reference chart that has the dosing for milligrams and the mLs that you're going to administer depending on the concentration of the meds that you carry. Whereas a Broslo tape's going to give you the total milligrams that weight range is going to need, but it doesn't always give you the exact mLs, so you've still got to do the math. So at 4 o'clock in the morning, it's good to have a handy reference sheet just to double check yourself.